So I've mentioned before that we now have a bounty of richness in terms of the therapies that we have available to manage patients with rheumatic diseases. And in terms of trying to differentiate between these, up until recently, we did not have many head-to-head studies. Head-to-head studies are now becoming available to us, and they do have different designs. For example, the oral strategy study was a study that compared Janus kinase 1-3 inhibitor to the same Janus kinase 1-3 inhibitor plus methotrexate to an anti-TNF agent with methotrexate. And in that study, what they did was they designed it as a non-inferiority study. That was not a superiority study. And what was found was that the Janus kinase 1-3 inhibitor was non-inferior to the standard of care, the anti-TNF agent plus methotrexate. Our studies have become a bit more aggressive. And in the Select Compare study that was more recently published, this was set up as a superiority study. And again, comparing a Janus kinase inhibitor, here a Janus kinase 1 inhibitor plus methotrexate to an anti-TNF agent plus methotrexate. And impressively, it was statistically significantly superior to the standard of care. So those are two examples in rheumatoid arthritis. We're also beginning to see head-to-head studies in psoriatic disease. And with regards to these, it's an evolving story because outcome measures are still not as clear-cut as they are in rheumatoid arthritis. For example, we look at ACR responses in patients with psoriatic arthritis, and whereas that's not a tool that you would ever use in the clinical management of patients with psoriatic disease, it's something that the FDA mandates. So there is indeed a study looking at an anti-IL-17 therapy compared to an anti-TNF therapy, both with methotrexate. And it had an interesting endpoint that is somewhat novel. It had both a skin, meaning a psoriasis endpoint, which was a PASI 100, and it had a ACR response, which was the ACR 50. And in that study, if you combine those two outcome measures, there was statistically significantly superiority for the IL-17 therapy. Now, we could argue about the validity of that outcome measure because it really hasn't been tested prior to this study. But nonetheless, here we are looking at a head-to-head study comparing the standard of care, an anti-TNF agent plus methotrexate, to a completely new class, which is an IL-17-driven therapy. So I think we're talking about really different classes. And if we are to focus on safety, I do think that that's a very important element with regards to choosing therapies, because you have to apply it to a specific patient. So if, for example, I have a patient who has had recurrent serious infections and who has diabetes and is on low doses of steroids, I'm going to try to use a therapy that does not have serious adverse events as one of its boxed warnings. And as an example of that, if we look at the anti-TNF class versus the IL-17, the anti-IL-17 class, the IL-17 class does not have a boxed warning for serious infections. So in terms of safety, in that type of circumstance, I would choose a IL-17 driven therapy. However, if we're still to focus on safety, I'm going to give you the opposite example, where I would choose an anti-TNF over an IL-17. So one of the safety concerns in patients who are treated with anti-IL-17s is that they can develop inflammatory bowel disease. And the data for that, I think, is evolving, but I think it's accepted that in some patients that is a risk that occurs. So if I have a patient who has had a history of inflammatory bowel disease and needs a biologic agent, and I'm making a safety-driven decision, I am not going to use the IL-17 class, and I am going to use the anti-TNF class, because here I would be killing two birds with one stone. Most of the anti-TNFs, not all of them, actually do treat inflammatory bowel disease. So in terms of the safety components across all of the classes, you do have to take that into account depending on the specific variables that are applicable to a given patient before deciding on treatment. If we were to go to the targeted synthetics as another example where safety would drive a decision, if I'm deciding between an anti-TNF agent and a targeted synthetic, one of the JAK inhibitors, in a patient who has rheumatoid arthritis and who happens to have multiple sclerosis as well, there's no way that I would use an anti-TNF agent, because in that type of circumstance, I know that I could make the multiple sclerosis worse, whereas the JAK inhibitors, as another example, do not. They don't treat it, but they don't make it worse. So I think knowing the nuances of the individual therapies that we're using and differentiating them not only in terms of efficacy, but as the question was posed, importantly in terms of safety, is an important determinant of which therapy you're going to use in a given patient.